Well, baby, you've been on my mind. I think about you all the time. Oh, I want to see your face. That don't make me wait.
Welcome back to Sleeping Around the podcast at night.
Oh, sleepy time.
So, Ann, I'm excited to introduce our next guest. He is not only a friend, he's not only a fellow baseball player in college.
Okay. But what position?
I am honored to have my good friend here. We have known each other now for going on 3 years. We have been in business together, and we've established a lot of collaborations. And it is my honor to introduce our next guest, Dr. Keith Matheny. You've done many podcasts, my friend, but for you to make time to be with Ann and I appreciate it. So welcome to Sleep Around.
Thank you.
Officially, welcome to Sleep Around the podcast with Dr. Ann and Matthew.
And it's funny in general how all of us, our merry band of sleep people, how we've all found each other, right?
Right.
People that are really passionate about sleep and appalled at how poorly we still care for these patients.
That's true.
And so, there's no accidents, at least the way I believe. And so, yeah.
Yeah.
If we had recorded this 7 or 8 years ago and you said, Keith, how much sleep do you do in your practice? I would have said, it's a major part of my practice. But what I would have meant at that time is I was triaging snoring patients. So usually in a full clinic, I would have 5 or 10 patients dragged in by their bed partner by their ear, just thrown upon my exam chair and saying, fix the snoring. And so I would order a sleep study that was done somewhere else, maybe in lab, maybe a home test at that point. And then I may never see the patient again. I might see them back to discuss the results, but I didn't interpret it. And I might discuss some treatment options, but then I never really saw them again. So I would argue I wasn't doing sleep at all, certainly not adequately. So the first step in fixing that, remedying that, was the adoption of home sleep testing in our practice. So I'm in a community ear, nose, and throat practice here in Dallas. We do have a significant amount of patients that come in seeking help for sleep disorder breathing. And so the first step we did was incorporate home sleep testing. We chose the WatchPat from now Zoll Itamar. And we jumped off a cliff, purchased some, now it's disposable, but purchased some capital equipment.
WatchPat 1? Mm-hmm.
Yeah, the WatchPat 1. And we ran those machines till the wheels fell off. And we realized how important it was for patients to stay with one provider as long as they could on this sleep odyssey they were starting. And so not only did that allow me to care for the patient, at least through the diagnostic tests and the discussion of treatment options, oh, by the way, it was a nice revenue stream for our practice too. So we recognized that it was good for the business and great for patient care. A few years after that, Dr. Heath Roberts, illustrious sleep dentist nationally, but one that I'm fortunate to practice with now in my own office, so here locally, he approached us and said, you send us a lot of patients to consider oral appliance therapy, but it would be much more efficient, much more streamlined if I was in your office delivering these oral appliances for the patients that are candidates. So this was probably 2 or 3 years into our the WatchPat testing program, and we implemented it, and immediately that was the next level of patient care improvement. The patients loved the fact that now they could come in to see us as a new patient, have their diagnostics done, discuss options. Many people their CPAP was their best option, so we'd send them out appropriately. But many people were at least candidates for oral appliance therapy. And now they could just go from my bank of rooms is 1 through 3. They could go down to room 7 and see Dr. Roberts and discuss that. And not only were they able to discuss that option, but the way we've set this up, and we'll, I'm sure over the next few minutes, develop the whole medical dental collaborative and the why and the logistics of it. But in many cases, those patients were able to obtain oral appliances through their health insurance. So the economics were really important to our patients. And again, as I'm sure we'll talk about too, I care very deeply about the business sides of medicine. And I work hard for my colleagues and I to run good businesses too, in addition to delivering the best in patient care. And this checks both boxes. So bringing the diagnostic testing in, bringing the oral appliance program in was great for the bottom line, but amazing for patients.
Traditionally, someone who would be seen by Keith or by any ENT, if they had any sleep issues, Keith would fix their nose and would fix other issues. And if they needed a sleep test, they would get referred out. And that process to receive a CPAP at that time, no matter, and this is before there was a recall or anything, would probably take a good 3 months.
So when you look at the current sleep practice, right, it's generally 3 months to get to a sleep doctor, right? Fair. And so then when you're talking about seeing the sleep doctor, there then is the approach of you need to have the clinic visit, you then need to have a polysomnography, you then need to have a CPAP titration. And so the reason I can say that I would counter that comment of 3 months and it being underestimated is because when we have looked at that, even within our own healthcare system, which is a very robust healthcare system that's able to get patients into where they need and outcomes, is that number one, we're seeing the referral to that is grossly inadequate. But generally, it is 1 year from time of referral to time of starting CPAP. And so because of the fact that it does take that long in order to get them into the lab or a home sleep test, et cetera. And that's talking about, in my healthcare system, we have 60 beds in terms of in-lab studies, and we have 400 home tests. So it's not as though that we're a small business or a small practice in terms of being able to move these pieces. Now, one of the things I would highlight is that when you're talking about sleep disorder breathing is that this isn't a one-trick pony. And so when we're talking about the typical approach to treating sleep disorder breathing, it is applied like it's one-trick pony because we're talking about you have OSA, we're going to give you a CPAP, and that's your treatment. But the reality is that this is a multi-level disease. And irrespective of if you're a CPAP candidate or not, it's still a multi-level disease. And so therefore, being able to make sure that you're looking at the multi-level and saying, how can we modify the airway to improve breathing is always the outcome we're looking at. And in fact, when you're talking about insurances typically don't approve ENT procedures for OSA. It has to be approved for I'm improving breathing dynamics. And at the end of the day, what we're doing in regards to ENT procedures is improving breathing dynamics, not because you only breathe at night. As far as I remember, I'm breathing right now.
And most of us do.
Well, we are at night, but yes.
Right.
And then you're right.
Podcast over.
And yeah, and watch this. I apologize. You're right. So what I was thinking of is before the pandemic, before the recall, I assumed it was 90 days. So I apologize. I do think it is a long time to treatment. My point on that was that by bringing in a sleep dentist into your own facility and then having the opportunity for EO486, which is our oral device, to be billed that way, is a game changer. And that model that Keith just discussed is something that we are trying to replicate across the country. And what it gives patients an opportunity to do is, unlike that system that you're still dealing with up there, we're able to get those patients treatment faster. What patients look for is the easy button. How do I make it the easiest way to get the treatment? Number two, for a company who's providing, how do we get that to the patient the fastest? So we know that with the pandemic and with the recall and with the statistics you just shared, which I know you're right because you were like a savant, that is too damn long. And we're trying to say that OSA is serious. And we're trying to put this emphasis that we've got to treat this patient fast, but yet we can't get them treatment, whether it be with surgery, whether it be with Inspire, whether it be with CPAP, whatever. Why are we not treating these patients faster? And what I've enjoyed with my relationship with Keith and USENT is that has been the sole goal.
And this is just the 1% that we're treating, right? I mean,
yeah.
A quarter of the planet's population is walking around with diagnosable obstructive sleep apnea, or certainly something similar. And we're maybe, even in the Western world, have diagnosed 10% of that. And we're maybe treating beyond 90 days 10% of that 10%.
Wow.
And then we're talking about, and it takes a year for them to get treated. As an ear, nose, and throat surgeon, I mean, I mostly do sinus and rhinology, sinus and skull base, and we'll talk about the nose's role in sleep, I'm sure. Mm-hmm. But that's not okay. I mean, right. This is not a social disease. This is not a comedy stand-up routine snoring. I mean, this is the most serious disease that an ENT surgeon takes care of, except for head and neck cancer.
We're talking to a general audience who I want them to be well informed of the fact that we're saying this is so emergent. We need to do all these things. However, we have such a shitty approach in regards to diagnosing, classifying that diagnosis, and classifying what the right treatment is for you.
Fair.
However, it doesn't mean that the end result is gross inaction over everyone, right?
Agree.
And so there does need to be this cautious balance of that. How we're going to proceed in this conversation is going to be talking about what are the tools available today in order to be able to, on a large scale, identify those who have sleep disorder breathing and provide interventions that are going to improve that. However, if you were to watch this 10 years from now, you're going to go, man, they are so out of touch,
right?
Because I hope and pray and am completely invested in saying, we're doing a shitty job right now, and you're going to laugh at us 10 years from now to say, man, they were trying so hard, but there was a better way. And so I just want to make sure that I'm putting on that platform of saying that everything we talk about right now is saying this is the best that we can afford at this moment in time. However, I expect a transitional landscape that we're doing much better 10 years from now.
What Keith is doing with USENT and this model that we just talked about with Heath Roberts is exactly that. And I think in 10 years from now, when we're able to look back, even on this exact podcast this night, people will go, holy crap, that was the way to do it. You bring the sleep dentist into the practice to work with experts in the sleep field that you're already testing for sleep. And so I'm a huge fan and an advocate, and that's what we've been trying to do. And how many current members are with USENT as we shoot this podcast?
Well over 1,000 physicians.
Okay.
And to put that in perspective, there's only about 5,000 ENT physicians in community practice. So there's 11,000 overall, but about half are in academic settings or employed settings.
What we're discussing tonight especially is like just so nuanced and so new. And I want people, that's why, obviously, besides being my friend, I wanted Keith on tonight to go, this is what we're doing. And we're doing it all over the country, and it's powerful.
Sleep apnea is a disease that occurs in the ear, nose, and throat. Right?
That's right.
And so while we're thankful and we're glad to work with our colleagues in pulmonology and neurology, we should have been all over this all along, and we weren't. But even though we're somewhat late to the party as far as the diagnostics and considering the full spectrum of treatments, at least we're here. And that's what I hope 10 years from now when we watch this back is we recognize we had the enthusiasm and the commitment to change it because it's not okay, right?
Well, you're talking again about the ENT role. It is a significant role. And so like I'm privileged to be at a center where we have a very robust interaction with our ENT. We in fact are one of 3 centers in Pennsylvania, for instance, that is going to have Inspire for not only adults but for pediatrics. And so with the Inspire program, which is hypoglossal nerve stimulator, is a surgical ENT procedure that then is going to connect to your hypoglossal nerve, which controls how your tongue moves, helps in moving your tongue forward in order to be a modifier for obstructive sleep apnea, has just achieved approval for 13 years and older for individuals who have Down syndrome specifically, because that is a population where 85% are going to have obstructive sleep apnea. Don't even get me started on the guidelines in regards to screening for obstructive sleep apnea and Down syndrome, because they're completely shitty.
And imagine a Down syndrome patient will not wear a CPAP or an oral device.
Yeah.
So
But never mind the fact that when you talk to most physicians who take care of individuals who have Down syndrome, that they'll tell you that they won't tolerate a polysomnography.
That's right.
And so even though the guidelines state by age of 4 years old, you should have a sleep study, the reality is that most of them are not having a sleep study. And then afterwards, the guidelines say, screen for symptoms of sleep apnea. However, recognize asterisks that the screening for historical symptoms of sleep apnea are grossly inadequate for predicting the likelihood of sleep apnea. Again, history and physical exam in pediatrics in general is a shitty way to go in order to identify obstructive sleep apnea. You put someone with Down syndrome in that same category, it's even worse. And the reality is that we now are not screening because we don't think that they can tolerate the polysomnography in lab, home, whatever you want to do. And then we're not offering treatments anyway. And then when we do, we're not seeing it successful.
Right.
And this is a population where it's not a matter of quality of life, right? It's not a matter of, hey, we improve your breathing. It's a matter of the entire life, because this is a population who, number one, have congenital heart defects, and those who have congenital heart defects are higher likelihood for acquired heart disease, hypertension, and every other type of acquired heart disease. We already know that untreated obstructive sleep apnea is going to aggressively enhance those things. Then you look at the fact that because they're trisomy 21, they have an additional ApoE gene, which makes them higher likelihood for Alzheimer's disease. We already know untreated obstructive sleep apnea greatly hastens your time to experiencing Alzheimer's disease. And then never mind every other factor that occurs in this population. So when you talk about the role of ENT, even though you want to say that you're late to the party, you play a critical role in this party, right?
Right.
That whether you are the primary diagnoser or not, having a willing, active participant in saying, this is a multi-level disease, that we're like, sign me up, I can do something to improve your breathing, is always a welcome to participant.
100%.
Yeah, and Ann, I want to go back to something you said earlier, about third-party payers not paying for nasal treatments in the context of sleep apnea. That is a real problem.
Mm-hmm.
So as we joke about, even if, as I always say, the nose is central in sleep disorder breathing,
100%.
literally and figuratively.
Mm-hmm.
And yet, this happened last week.
It literally puts it's right in the middle of my face.
Right. I could. That's what I mean. It's literally right in the middle. Some of us is a little more off to the side, but in general, it's central.
Okay.
And
I got a fat nose.
this happened last week where I had a patient that I proposed to the people that really practice medicine. Some person that works at one of the third-party payers.
Yeah, they
tell me what I can and can't do because they know everything. And I wanted to simply do a septoplasty and a tonsillectomy at the same time. And someone with a significantly deviated septum, 4+ out of 4 tonsils, and sleep apnea. And they would not let me do the septoplasty because that is not an accepted treatment for sleep apnea.
Yeah.
Wow.
Even though, obviously, it contributes to the disease.
Yeah.
But even though...
Is it an accepted treatment for like breathing in real life though? Like, because
it is,
at the end of the day,
dissociate them.
That's what I was going to.
Yeah.
And even though most people or a lot of people are prescribed CPAP to begin with, which is delivered nasally, at least partially.
Mm-hmm.
So you have to alleviate the nasal obstruction at least to treat these patients, and they still wouldn't let me do it. Yeah. So what we have to do is now wait, and 90 days, the next year's deductible, take out the diagnosis of obstructive sleep apnea and try to approve the surgery again. So that third-party payer is now paying for 2 surgeries. The patient has to have 2 surgeries and pay
separate
or it's completely separate, at least 90 days apart.
Wow.
To pacify the system as it is.
Let me ask you a question just personally, because you've experienced this. I know for me, who's had major surgeries, I really have. I've had major surgeries in my life. For me to come back in 90 days to have another surgery to be, what's the likelihood of them coming back?
Yeah, well, certainly these are quality of life things.
Yeah.
Now, we all believe it's life or death.
Yeah.
But it's chronically life or death. And so patients think it's more of a nuisance, right?
Mm-hmm.
Wow.
And so the likelihood is low, Matthew.
Okay.
And that's the problem. When we talk about dementia, multiple anesthetics is also a risk factor for dementia, right?
Yeah.
And I could have spent another 10, 15 minutes fixing that young lady's septum. She's in her early 30s. And now she'll have 2 separate anesthetics. So besides the cost, besides the logistics of getting
taking
her
off work,
kids
driving,
taken care of, taking off work, all that.
We now know that every time a child is exposed to anesthesia for sedation, whether it's for an MRI, whether it's for dental procedures, whatever else, those are things that we're taking off your IQ points. And not necessarily, and I want to make sure that I'm not emphasizing it in a degree to where parents are watching this and going, I will never sedate my child for X, Y, Z. But this is something that we have become extraordinarily mindful of, is that do we sedate them for this procedure and then separately sedate them again? But no, we're trying to coalesce those things because of the fact of the point that you're stating is that we need to recognize that every single thing we do to patients, there is a potential consequence for those patients.
Sure.
And in addition to that, when we're talking about an individual who, even if the goal is saying we're going to believe that CPAP is the right therapy, and one of the things I want to make sure, because we have a lot of different episodes where we're talking about alternatives to CPAP. CPAP is a fucking great therapy, right? It's a great therapy. And I do not want to de-emphasize the fact that CPAP, BiPAP, ASV, they're great therapies.
My daughter has been on it for hers for years and been loyal. Yes, I'm with you.
But at the end of the day, if I optimize your breathing dynamics, instead of you needing a BiPAP of 15/10 or a CPAP of 12, I can now get away with a lower pressure because I removed the reasons for resistance that are further modifying your sleep disorder breathing. And so the reality is, at the end of the day, one of the things that we're continuing to encounter is our favorite topic is that the insurances where they're just saying that it's deny, delay, obstruct healthcare for us to be able to get patients to the right outcome, for us to actually do the things that insurances are there for, which is risk mitigation, right?
It behooves them to do it.
Yeah.
Too.
So the reality is that although it behooves them to do it, it behooves them for the long term. And insurances aren't about the long game. They're about the 1 year where they can guarantee that you are going to be the person who we insure, because next year it's a wild card and you may not be the same person who I'm insuring. And so the reality is that we continue to work on saying, how do we continue to risk modify for your short term in order for the insurance to say it's worth for me to pay this cost, because I'm guaranteeing that next year it's going to be someone else's problem, not mine.
You're going to get knocked off by one of these companies if you keep. They have a lobbyist and gang members.
Hey, you know what? They love me so much. They invited me to speak at their conferences.
I bet they did. You know when they did? We got a private flight.
I had like standing ovation by end of it. And we were like high-fiving, hugging. I literally had people hugging me, telling me like I changed their lives.
Yeah, as you're hugging, they still
stabbing the knife.
Et tu, Brute. So Keith, we've talked about like the future, and one of the things Ann brought up, and I really appreciate you. You're so amazing. What do both you guys kind of see as kind of the future of kind of where we're heading? Because I know we can always gripe and complain. I like even your example of CPAP, but what are some things that are coming down the line that maybe you two know about that you can share with our audience?
What's been interesting to me is to look at various types of monitoring of these patients on a nightly basis. And I think this speaks to identifying the disease state earlier. So all these things that we wear all the time can give us clues on whether someone has sleep disordered breathing. And so I'm really fascinated and separate from USENT. I've been a part of a company called Sleep Vigil that's looking at this remote monitoring of this patient population, specifically obstructive sleep apnea, but it could really be a lot of different sleep disorders on a nightly basis.
Mm-hmm.
So most of us customarily can do a formal sleep study on these patients every 3 years, every 1,000 nights. With remote monitoring, we can then essentially do a sleep study every night. It's not a formal sleep study. I don't want to be hamstrung by my words here, but you can get an idea of how that patient is sleeping. So some of our early studies in Sleep Vigil has been eye-opening in a bad way. As we get away from AHI and we start looking at more meaningful parameters such as the hypoxic burden,
SO2,
the amount of time per night that a patient is suboptimal with their oxygenation. It's scary, the people that we think are optimally managed, how much hypoxia they're still having.
Sure.
So this remote monitoring affords us the opportunity to improve that, whether it's advancing their appliance, it's giving them another centimeter of water pressure on their CPAP, whatever, to get them above 90, above 92% the entire night or most of the night. I think that's where we can really impact. So the finish line is not, okay, I'm writing you a prescription for CPAP, enjoy that the rest of your life.
You made it 90 days, you get to keep it. Right.
That's really the starting point. Everything else is prologue. And we need to monitor these people frequently, maybe not every night, but many, many, many nights to ensure that we're treating them correctly. That's what I think, and obviously there's all kinds of AI applications of that I'm sure will be developed over the next few decades. But that's where we're going to impact dementia. That's where we're going to impact, workplace productivity, motor vehicle accidents, whatever, because people in general are going to be sleeping better and more effectively.
My role at my healthcare system is very, very much involved in digital transformation. And one of the things that I'm most known for is that I truly believe in the complete disruption of healthcare and just blowing it up and rebuilding it. So I'm very privileged at our healthcare center. We have the Seal Institute for Innovations, and I'm the clinical lead for most of our pediatric efforts, but I do have the privilege of working alongside of our adult. And one of the things at my healthcare system is that we're known nationally and internationally for all the work we do in regards to innovations. And we're a leader in regards to remote patient monitoring. We have a great partnership with Best Buy, with Current Health, and doing at-home monitoring and doing a lot of remote patient monitoring. And so one of the things in regards to RPMs is that recognizing that this is something that we are now empowering patients to be able to better drive healthcare delivery. Now, when you're looking at some of the things that you're stating in regards to oxygen burden, we now are seeing that increasing research is saying AHI is not the right thing. Mount Sinai just published a whole thing about respiratory vulnerability. And then the most important thing is that Cleveland Clinic had just done an analysis of over 40,000 individuals who had polysomnographies done, and what they had stated is exactly about oxygen desaturation. And what they had demonstrated is that we knew since November of 2020, the American College of Cardiology had come out and stated those who have atrial fibrillation, right? We need to do sleep studies on them. We can't just screen them with questions, because the fact that we just screen them with questions, we get about 60-something%. When we do the sleep studies, we get 80-something% who have obstructive sleep apnea. So at that point, we're going, obstructive sleep apnea is an independent risk factor for atrial fibrillation. When you then have a study that was published a few months ago that was saying those who have paroxysmal atrial fibrillation, the longer duration of time that they're spending in desaturations, the higher likelihood they are to then have longer durations of atrial fibrillation. So now you're seeing, okay, so there's an oxygen thing. What the most recent study that was just published, I believe it was even this month, maybe last month, is stating that those who have obstructive sleep apnea, not a diagnosis of atrial fibrillation, you follow the oxygen desaturation, you find those who have atrial fibrillation. So what they identified is those who have obstructive sleep apnea, there's an incidence of development of AFib of about 5%. However, when you have a desaturation of 10%, 30% will have atrial fibrillation.
Wow.
And so now this introduces this whole idea. So the question that this study doesn't answer is going, so we know OSA, and you have these DSATs, introduces this high likelihood of developing AFib. However, we're doing all of these studies, even though we're only approaching about 1% of those who do have OSA. When do we do the AFib monitoring? And what kind of AFib monitoring? Do we do an EKG? Do we do a Holter monitor? Do we do a loop recorder? I'm a neurologist. So I go, we know that AFib is an independent risk factor for stroke. And if I have someone who has an embolic stroke, I can't do an EKG. I can't do a Holter monitor. I have to do a loop recorder because...
Is a loop recorder...
Loop recorder is about a month. It's like about a month worth of looking at the EKG.
But is that the ambulatory monitor that they wear? I swear.
It's a loop recorder is a longer duration of looking at EKG monitoring.
But
it's
like
about a month
24
long.
hours a day, 7, like
Yeah,
ambulatory?
it's like 30 days long.
Okay.
And so loop recorder basically is what is needed because of the fact that we know that paroxysmal AFib may not be present for at least 28 days.
That is...
So now we're at this really interesting juxtaposition of saying, when do we monitor? When do we ask this question? Right. Because we know 30%, so 3 out of 10 people who now have this OSA with this 10% desaturation, you're going to have AFib. And I need to recognize and intervene because that's going to have a fucking shitload of impact on your life, because you can have MI, you can have a stroke, you can have all these other adverse outcomes. And now when do I screen you for that? And so what RPM now introduces, right, is number one, an opportunity to empower the patient to have more data collection. So I cannot drive this home enough. The reality is what drives the response of a physician is data. And if I have collated data that is serially collected, that is going to give me a better picture of what you need, that allows me to give the right care for the right patient at the right time. And at the end of the day, that's what precision medicine is all about. It's not about me purely saying, I have your genomics, I have your phenotype, I have all of this. It's a matter of saying, how does this all look today, tomorrow, and what can I predict you looking like next week? And RPM is the state that we're looking at.
Agreed.
And so one of the things that is really important is that when people go RPM, so isn't that a sleep test? Isn't that a home sleep test? No. RPM, remote patient monitoring, is different from many of the modalities. So one of the things that I give a lot of guidance on, especially for industry partners, so pharmaceutical companies who are going, we're doing this study on this drug and we want to know the benefit of it, and we're going to do actigraphy. And I go, don't waste your time or money, because actigraphy, number one, insurances aren't paying for it anyway because they believe it's experimental, which insurance companies, actigraphy has been around a long time. It's no longer experimental.
They love to send that to patients. Your doctor wants to do something experimental.
Exactly. We know that it's very beneficial.
Yeah.
But the reality is for me, I tell all these companies, don't do actigraphy, do remote patient monitoring. Why? Because number one, you're going to get that sleep data that you want, but you're also going to get all the other variables that are important, not only to be able to say, we have not increased your risk utilizing this. You're not changing your heart rate, your oxygen saturation, or any of these other vital signs. But now you've created an actionable item that is also potentially billable, which every healthcare system is going, how do I actually pay for this advancement in care for this precision medicine? It's a billable model that now you're also able to utilize to actually change the outcome of patients. So when we're talking in this like waving of hands about value-based outcomes and saying that the things that we want to do actually change the value proposition for the patient, this now is a modality that actually can do that.
I'm wearing one of these.
Mm-hmm.
And
a wedding ring?
No. Remote patient monitoring. This just happens to be a Circle Plus.
Is that because you're freshly out of jail?
A Circle Plus. No, that's my ankle monitor. What I have learned in the very short time wearing this, and I shared this in an earlier podcast, is I need help. And for a person who co-hosts a podcast and works in the sleep industry, I was blown away, and it made me feel part of the process. I can imagine someone who is really struggling. And we've been fortunate enough, and you guys see it on a daily basis, someone who's truly struggling with obstructive sleep apnea. It kind of gives them a part in that too. I was blown away, guys, just by, I'm a pretty healthy guy. I've been working on that over the last couple of years. And just to see my numbers, I think it for the patient and for the person, it kind of puts me in charge and makes me accountable for my health.
It changes behavior. I mean, think how we're all so used to looking at our steps and did we close our rings and on our fitness tracker. And what we've seen at Sleep Vigil is just that it becomes habitual and positively reinforcing.
Oh, totally. And it challenges me. And now this could be my personality because both you guys know me well. So I take it like, I got to get better. I got to do better. This is a challenge to me. And I'm not saying everybody's like that. Some people they might get it and go, oh, well. Yeah. But it's that accountability factor. But it's also the accountability to my physician. It's the accountability to what I'm wearing, whether it be a CPAP or an oral device. And so I am so fascinated by the future. I love that you shouted it out there, and you literally shouted, by the way.
I know.
Because I am curious. And my hope with this podcast and my relationships and the connections that I've made in the industry, that in 10 years from now, we do look back and go,
we should never look back and ridicule ourselves. This is the step, right?
Yeah.
Right.
I mean,
I am just blown away. So this ring and remote patient monitoring gives me hope.
Yeah.
For my daughter who wears a CPAP every day, still to this day at age 19, for individuals to choose to watch their oxygen, more importantly than AHI, as Ann profound, pointed out.
And that's where AI can help us. We're getting so much data now. So you were talking about when do we start monitoring and what do we monitor? Do we monitor heart rate and rhythms? Do we monitor the oxygen? So again, our lovely third-party payers in general only let us monitor one thing.
Yeah.
At least they let us monitor one thing. But similar to how I couldn't do the septoplasty and the tonsillectomy at the same time.
Sure.
We can't monitor blood pressure and heart rhythm and oxygen at the same time and
Yeah.
get paid for it. We can monitor it.
Yeah.
They're happy when we do stuff for free.
Yeah.
But that's what needs to change is when we get that much data, then we can predict where and how long we have to monitor people. So do we have to monitor them every day?
Yeah.
Or can we take a 3-month or a 1-month snapshot every year? You know, at some point we do have to, as healthcare providers, we have to be responsible with resources
Yeah.
too. And we don't look at the third party payers as blank checks either. We all have to work together to deliver more efficient care.
Yeah. And at the same time, we also are responsible to the patient because information isn't always good information, right? And so what I mean by that is that in the current climate where you can monitor everything, so there's a lot of consumer devices, is that we're also seeing in the same capacity of what's been viewed as beneficial for Matthew, there's plenty of people out there where it actually has created sleep problems because they're trying to achieve an unrealistic score. My sleep score is a 72 and I need it to be an 85 because I achieved this 85
I
once.
saw something today.
And so
this
that
8-hour rule, people
exactly
Right.
with insomnia, they're obsessed with, I only slept 6 hours.
Yeah. Well, I
that may
think-
be fine,
yeah.
but they're thinking they're
And
falling
the
short.
reality is that we as a field also are making a lot of mistakes in saying like, oh, the current study doesn't say duration, it's regularity of sleep. Oh, the regularity of sleep doesn't matter, it's the duration of sleep. Oh, it's the quality of sleep. And so at the end of the day, it's saying that no one has ever said your blood pressure doesn't matter, it's just your heart rate. Your body temperature doesn't matter if your heart rate is okay. If your blood pressure is erratic, then like you can't dissect the homeostat and say that only one parameter of the homeostat matters, right? It all matters and it all needs to align. It's just not that everyone's exactly the same, right? And so the reason why there is a range of what is normal is because there is a range of what is normal. It doesn't mean you then can piecewise and select what you accept as abnormal. Absolutely. And so very frequently, one of the things I drive home is that there's a lot of things that are common. It doesn't mean that those are normal. And so at the end of the day, as we increase the amount of information that's available, it is our due justice and our job and our responsibility to make sure that as this information grows and how much we can look at, that we're also normalizing what is acceptable and within range and okay versus making people preoccupied with numbers and metrics in a incidental period that actually don't change anything. Because there's a lot of people who are like, I didn't get enough deep sleep. I didn't get enough REM sleep. I didn't get enough of the sleep score, or my oxygen went down to this for like 2 minutes, which might have just been my ring wasn't on the right way or my watch was on the right way. And so it is our responsibility to also be a partner with the people who are utilizing these to ensure that the information is being utilized in the best way.
I know that USC&T has some amazing vendor partners, part of the GPO. I definitely want you to highlight that a little bit before we have to get out of here, because what you guys are doing, and we are a sleeping podcast, is amazing. But I also know that you guys offer many other things.
Well, thank you. Well, I mean, I think it all starts with the fact that we go to school till we're in our mid-30s. Not Ann, she's just,
Yeah, Ann's
Now,
barely.
late
Ann
20s.
told me she's 40.
right.
I'm 40. I'm 40 years young.
So she's
That'll
just
believe
finished training, right?
Yeah.
But
Brandy, no.
in all that time, we never have 3 semester hours of business, or
No.
most of us do. And then when we finally graduate, or we finally say uncle and we're done training, we don't do one more fellowship. We're unleashed on these multi-million-dollar businesses. And as you might expect, they're not run very well.
No.
And we're trained by folks that are working in academic institutions. So they're employees. They're magnificent, brilliant people, but they also don't know business, and they don't even practice in a setting where they can learn it from the School of Hard Knocks. And my experience was no different. When I finished my training at Vanderbilt and I came back to Dallas where I grew up, I joined 2 wonderful physicians at the time. One is retired now, one still practices with me. And I was extremely busy from day one from a patient flow standpoint. But really everywhere else we looked in the practice was an opportunity for great improvement from a business standpoint. And I can go into that a little bit, but we were by a dying hospital. We At that time, 20, 25 years ago, we had a 30-year-old clinic with 30 years of dust everywhere, old decor, old equipment. The staff itself was a conglomeration of 3 different groups that the practices had merged, and so those groups didn't really mesh, and that showed forth in poor customer service. We had no website. Again, this is not 50, 60 years ago. We had paper charts, revenue cycle, billing and collecting was a mess. Our ancillaries, part of ear, nose, and throat, is we have so many service lines like offering hearing aids, allergy shots, cosmetics, sleep, of course. If they even had those in this practice at that time, they were losing money. And some of them are retail opportunities, so it's hard to lose money, but they figured out how to do that. And so I was extremely busy, but I describe those days as busy in spite of our surroundings. And so because most of my colleagues, your colleagues, just really want to focus on patient care.
Yeah.
And that's noble. That's wonderful. I took over business operations even before I was physically, legally a partner. And through a lot of good guesses and learning from mistakes and great advice from other people, we transformed our practice over 4 or 5 years and moved out of the situation we were in into 3 modern offices. We were paperless. We'd figured out how to work well with, we would call them mid-level providers, but they're now called APPs. They reinvented their name. All of the other service lines, we either, I saw that look. Yeah. We turned them around and made them profit centers for our practice because we can't care for patients if we go out of business, right? Mm-hmm. So we don't need to apologize for running good businesses. We implemented new service lines, and so that led to other practices around here informally asking us for help. How do you bring on a PA? How can you help our billing and collecting? Can you fix our hearing aid department, whatever? That then led to a more formal consulting company, which exists today, but it's the underpinnings of what you've referenced called USCNT. USCNT is a GPO in legal structural. That's a group purchasing organization. So it's a legal structure that allows us as physicians to buy in bulk, like some of these large stores that we all shop at. Mm-hmm. And that brings significant savings. ENT is a very expensive practice to practice. We each spend individually hundreds of thousands of dollars a year, not as a practice, as an individual physician, just on the supplies and the services that we need to deliver care. And so we must, as reimbursements go down, we must run good businesses. And so that's what USCNT does. Day one is cost savings. We have about 45 contracts with people like Somnomed, like Zoll, Itamar, the hearing aid companies, the sinus balloon companies, all of that. And that brings about 20% savings across the clinic. But cost savings really is just day one. From what I preach to the team all the time, and they're rolling their eyes if they're listening to this, from day 2 to infinity is helping them run better businesses. So cost savings are great, but now let's look and help be efficient and implement new revenue streams. And how I started this was almost with an apology how ENTs may think that they're doing sleep, but they're like me 7 or 8 years ago and they're not doing sleep. And so we're working our asses off to try to change that, where we truly are doing sleep in collaboration with sleep dentists, bringing in the diagnostics and doing the remote monitoring.
For an oral device company to be part of that is just a blessing. We are such a small part, and I love what you guys do to treat patients. Keith, are you a sock, shoe? Are you a sock, shoe?
Sock, shoe, shoe.
Thank God.
Now, I just met you, but this is such an important question. Are you a top or a bottom in bunk beds?
In bunk beds.
Yeah.
You like how she pot?
The pause for effect.
As she's holding the mic, just throwing it out there.
Top.
Really? Okay. Wow. All right. With you and your bed partner, very specific, are you a snuggler and change this question. I like the way you changed it. Are you a snuggle then get away?
I'm probably more of a sleep close but independent.
Go for it.
Nude or jammies or boxer
Nude.
brief? Oh.
Nude, yeah. Yeah.
I think we have 3 nudes.
Yeah.
Do we have 3
No.
nudes?
No. No.
I thought you were a nude.
No, my husband wishes.
She's almost perfect. But
No.
nobody's perfect.
Keith, I can't thank
Exactly.
you enough. So you're an amazing ENT. More importantly to me, you're my friend. And I just can't thank you enough for being here. Thank you for sleeping around with Dr. Aaron and Matthew.
And we're just keeping it between sleep friends.
That's right. Thank you, brother. Appreciate it.
Thank you both.